Hello. So this is the first part, integrity, and the reason of care of the newborn. The reason why I didn't record this is because the class split up into half. One was, uh, and everybody partnered up, one PEDS person and one OB person, just as a refresher, because you guys have had all of this information in orientation. And so what they did was they filled out the first part all the way up to bonding. They filled that out together. They had about a half hour and they filled in all the blanks. And then I asked them and they answered the questions. So I would prefer you go through this integrity, go through your notes and the book in the blank integrity that I email to you. I would prefer that you actually do that and fill it in, because I am going to give the answers very quickly. So it would probably be easier for you if you did that, but it's up to you, I guess. So assessment and care of the newborn. Here's our objectives. And I will say that you have had all of this in OB orientation. And so truly, this is all stuff that you should know. Okay, so right away, after the baby comes out, what do we want to do? Most important thing is that the baby is breathing. So you want to maintain those breaths. So we monitor the breaths, we monitor the heart rate, we give oxygen if we need it. Provide and maintain warmth. We're drying the baby off, maintaining the warmth by keeping the baby's skin to skin on mama. We will immediately after birth just do a very quick physical assessment. We're checking respirations, we're checking pulse, looking on the outside of the baby. And that's, basically we're looking at the APGAR score issues. Before the baby leaves the room, mom and the baby have to have matching identification bracelets, and then usually the significant other also has that. All right, so here are our normal newborn vital signs, and you should know those. APGAR scores are performed, it says performed immediately after birth, but the APGAR scores are at 1 and 5 minutes. So, and the 5 parameters that we look at to assign, and each parameter is worth 0, 1, or 2 points, heart rate, respiratory rate, and then we look at the muscle tone. Reflex irritability means, are they crying? Are they scrunching up their face? Or are they just very, placid? They're not moving their face at all. And then the color, of course, generalized skin color. And there are people who will say that no baby can have a 10 and a 10 because they will always have some of that acrocyanosis. So usually the highest number that they get is 9. Okay, and then here is the actual chart and how you would score it. Okay. All right, so these are the things that they have to be able to do, and these are the things that we really work on in those first 24 to 48 hours, 72 hours. This is what the nurse does. We're watching to make sure that they have a clear airway, that they keep warm on their own, that their vital signs are stable. We check all their reflexes. We will do the measurements once, and then they weigh the babies every night at midnight. And then we really want to promote bonding. That's a huge piece. Mom is in the taking in phase. We are promoting the taking in phase and making sure that proper bonding is happening, because there are some signs that it's not. First feeding right away. We want to get that ideally within 30 minutes. Now, if the baby has to go to the NICU right away or something's wrong with mom and they have to be separated, it doesn't mean that they're not ever going to bond correctly. It's just the best time to do it is in those first 30 minutes being skin to skin. Even if mom isn't breastfeeding, skin to skin right away helps with the respirations and the temperature control. So we're looking at, and you know how to elicit all of these reflexes. So, and obviously you're going to need to, know how to do all of these for your clinical on July 3rd, hopefully. Okay. And here's the baby doing the stepping. And what the baby's doing, the tonic neck there. And I just have to pause this for a sec. Okay, so the picture on the left is tonic neck, and the picture on the right is Babinski, and we stroke up to elicit that, and a positive Babinski reflex in newborns is normal. Grasping, from left to right, grasping, plantar grasp, rooting, and Moro or startle reflex. Okay, and then you need to figure out, so at 15 minutes of life, the newborn is crying vigorously, or 5 minutes of life. So this is our second APGAR. So crying vigorously, so that's 2 points. Has a heart rate of 118, that's 2 points. Good crying, so respiratory effort is good cry, that's 2 points. Pale blue body and extremity, so that's 0 points. So what are we at? I believe we're at 6. Has slight movement of extremities, 1. So that would be 7 points. And that's how you figure out that APGAR score. Okay, and then we used to, on every baby, do a gestational age assessment. So we could figure out, we have, our ultrasound due dates. We're not totally sure. They're not perfect. They don't tell us exactly. So the Ballard scale used to be called the Dubowitz scale. We look for to classify babies by their gestational age and their birth weight. So sometimes babies can be born and they're very large, like a baby born from a gestational diabetic or a diabetic mother can be very large even at 35 weeks, okay? So we look at several things. So we're looking at their weight, and we do 2 exams, and let's see. So we're looking at neuromuscular maturity, and then we're looking at physical characteristics of maturity. And the farther you go to the right, the more mature the baby is. And now they don't do that unless there's a question, but you should know what it is, okay? So, and these are the things that we look at. Obviously, the more mature they are, they're going to have more creases, less lanugo, drier skin. You'll feel breast buds. They'll be, there'll be more cartilage, like in the ears, so you'll have recoil that's quickly, genitalia that's more developed, and then they look at different neuromuscular activities, and then they will go ahead and plot the weight and the gestational age to decide if they're large or average or small. Okay. All right. And usually that's only done when there's a question how old this baby actually is. So the nurse tests the newborn's Babinski reflex by doing which of the following: changing the equilibrium, placing a finger in the newborn's hand, stroking the lateral aspect of the heel upward, touching the corner of the newborn's mouth and cheek, and obviously it is D. Okay, so we talked some about this. Immediate interventions. We give vitamin K. There's on page 569, you can look at the medication guide. We give it IM. We try to give it within the first hour of birth. It's a prophylactic to prevent bleeding. Think about how it produces bleeding, how it prevents bleeding, because it activates the clotting factors. Babies have a sterile gut, so they cannot make vitamin K until their gut has some normal flora in it. So that is why we give it. Normal newborns, day 8, can make their own. Okay. All right, and this is where we give it. We give it in Nevastus lateralis. At Sanford, we give it on the right side, and then we give Hep B on the left side. Okay. Some of the other things we do: eye prophylaxis. We put erythromycin ointment in case mom's vaginal canal has gonorrhea or chlamydia, so the baby doesn't catch that and become blind. And you can see on 569 the medication guide, so you can have more information on that. And there is an actual picture of it. Umbilical cord care is going to be different depending upon the institution, but we use the best research that's available, and water decreases that actual drying time. And remember, when we're doing cord care, we use a wet Q-tip, and we're basically breaking up and wiping off all the oil that's on that cord stump, and then we dry it with a dry Q-tip, and once all the oil is out, the air will dry that cord stump faster. We do not remove our cord clamp until the baby is just about walking out the door, because we use that for identification. But this is them taking the cord clamp out, and you can see the cord is crusty and dry. And that's what it looks like afterwards. Sometimes you can trim this stuff if it's really pokey. And then, you know, it can take up to 3 weeks for that stump to actually fall off, and this is what it looks like. And we teach parents to do what? They need to do cord care with every diaper change at least 4 times a day. The more they do it, the faster it will dry up. And this is our blood glucose level. We do check a blood glucose level. Now we get babies feeding, even if they are sucking, and actually even skin to skin will increase their blood glucose right after delivery. So, excuse me. Babies who are at risk for low blood glucose level, premature, post-mature, LGA, SGA, if they're cold, if mom has been ill. And then what are the symptoms of neonatal hypoglycemia? Oh, and I'm sorry, when we're talking about the cord, you need to be able to verbalize to the parents what are the signs of an infection in that cord stump. Okay, so symptoms of neonatal hypoglycemia: jitteriness, hypotonia, poor suck, apnea, low temp, irritability. I always think it's kind of ironic because they need to eat to get their blood glucose up, but when they have a low blood glucose, they sometimes have a hard time sucking. Okay, so when we're drawing blood for babies, we want to avoid this area in the middle because we don't want to hit the nerve and damage. Baby could have numbness for the rest of its life, so we try to hit the sides, right, the outer sides when we do a heel stick. And this is a baby getting a heel stick. It's really important to get everything very warm before, so the blood flows nicely. Okay, nurses instructing new parents on cord care. Which of the following is the most important thing? It's done to control bleeding. It's the best. Alcohol is the best drying agent. The process of keeping the cord clean and dry will decrease the chance of bacterial growth and facilitate drying. The cord will fall off in 7 to 10 days. Obviously, number 3 is the most accurate. Physiologic jaundice, we talked about that. We didn't talk about hyperbilirubinemia, which is when there is too much bilirubin, unconjugated bilirubin, so baby's getting yellow from head down. If the bilirubin level is too high and it's going up quickly, we need to help the baby kind of conjugate, break up that bilirubin. And so we put the baby under UV lights, so phototherapy, and we have to watch for temp instability, hypoglycemia, and hypoglycemia is another physiologic problem. But babies who have soft tissue injuries or lacerations, anytime there's bleeding anywhere, bruising, a lot of bruising in the face, this is a cephalohematoma, this is caput, and so these two are bleeding, you have a chance of having a higher bilirubin because there's more lysis of the red blood cells. Okay? All right, and the difference between a cephalohematoma and caput is where it is in the scalp. Caput secundum is just serum edema. It's swelling, okay, in the scalp, and it crosses suture lines, okay. This is a cephalohematoma. It's a collection of blood in the scalp. It does not cross suture lines, so you'll see kind of a horn on one or both sides of the head if it's a cephalohematoma. It's also harder, tends to be hard, takes a long time for the body to absorb this, and since this is all going to be lysed red blood cells, baby will have a higher unconjugated bilirubin, for sure. Okay, this caput will feel kind of spongy and soft. And this, oh, oops, I did not mean to do that. This is a baby in phototherapy. We have to protect their eyes. We have to make sure they don't get dehydrated when they're in phototherapy. Now we actually have blankets that we can wrap the babies up in, so their eyes, we don't have to worry so much about their eyes or temp instability. So, okay, some of the other things we do, metabolic screening, we call it a PKU. PKU is just one of the tests. It was the first test that they look for. There are actually hundreds of metabolic screens that they do from that. We do a heel stick. If for some reason we're like drawing a bilirubin, we need more blood, we will do a venipuncture. We use urine bags to get a urine specimen. And we, always try to have a holder, somebody to hold the baby. We swaddle everything but the area that we're going to be taking the blood for, so the baby doesn't move too much. And so this is getting a urine specimen. If we, for some reason, can't get one from putting a bag on, they can actually go and do a suprapubic stick and actually put a needle in and pull out urine directly from the bladder, and it just seals up. It's pretty cool. Okay, so this baby looks like he's in big trouble, but it's actually a hearing test. This is the kind of hearing test that we do now, and it basically is checking that there's bone conduction to the auditory nerve. But it's so important for babies who have trouble hearing to get some help right away that we are now testing all babies in the nursery. And sometimes their ears have water in them, and so they can't hear as well. And so they don't pass on one or both ears, and then they have to come back in 2 weeks and get another test. And this is, we did a heel stick for the metabolic screening. And again, we call this the PKU. We let these dots of blood dry. They get sent in, and I don't know if it takes 2 weeks or a month to get the report. So, video, neonatal assessment video, and this is a head-to-toe assessment, is in the textbook. There's a video in the library. You can YouTube it. Also, physical assessment of the newborn, and then assessment of the reflexes is there, so you can review that on your own if you don't remember. And then large head for body, what they really look like. Umbilicus is in the center. They have a rounded, prominent abdomen, and that's normal. They should be flexed if they're term. And then here are the averages for the weight, length, chest, head. Okay, for the skin, acrocyanosis, remember what that is. Vernix, you need to know what that is. The Harlequin sign is what I talked about. It's just in a short period of time. Sometimes it lasts only seconds, but 1/2 of the baby's body is blue. Kind of gets at least dusky. There's a clear colored division over the body from the head to the abdomen, with one side red and one side is pale or even blue. And it's just like a little constriction of the vessels. And it can last from 1 to 20 minutes, and it's transient. It's something that just happens. It means nothing clinically. It's not a big deal. Mottled skin, when I see mottled skin, I worry about the baby being cold. That physiologic jaundice, remember the difference between physiologic and pathologic jaundice. And erythema toxicum, if you remember, that is the newborn rash. Milia are the little clogged sebaceous glands, the little white spots. So here, up here, this is mottling. This is milia. This is where you usually see it. This is newborn rash. This is newborn rash. So can be pretty significant, those darn newborn rashes. Telangiectatic nevi, stork bites. I'll show you where you see those in a minute. Mongolian spots are for people of color. They look like big bruises. They're usually on the buttocks, the hips, the legs. And you can blanch them to tell the difference between a Mongolian spot and a bruise. We should always measure the Mongolian spots once at least in the nursery, so they are on the baby's record in case they ever parents get accused of bruising and child abuse. The nevus flammatus is the port wine stain. Oftentimes we see port wine staining on the face. And so that is like a purple mark on the skin somewhere. Nevus vasculosus is a strawberry mark. It's just a little red mark. It's a collection of capillaries in one spot. So these are stork bites. You can see on the in between the eyes and over the eyes. Those are stork bites. They fade pretty quickly. And then this is a very common place for stork bites. It usually fades within a couple months, but like a lot of times people who have stork bites, if they are stressed or mad or whatever, it will come back. You could still see my stork bite at times. Okay, and this is just a picture of our Mongolian spot. You've seen that before. Or several Mongolian spots. There's actually one here, too, here. And you can see babies of color tend to have a lot more hair on their bodies. Okay. All right, when we first see the head, if there may be molding if the baby was in the birth canal for any length of time. We often don't see it with C-section babies if mom hasn't labored beforehand. Molding, all of the bones in the skull, maybe they're not connected solidly. They're not fused. That's the word I was thinking of. The bones aren't fused, and so that they can go over the top of each other to squeeze that head into the birth canal. We look at anterior, we assess anterior and posterior. Fontanelles, we're assessing them for bulging. If there's bulging, you may have increased intracranial pressure. If it's depressed, you may have, baby might be dry, not hydrated. They should be flat and soft. We look at hair distribution, check for cephalohematoma and caput, and we talked about those already. Eyes. Babies can cry and not have tears because their lacrimal ducts are immature, so you don't usually see it too often. Sometimes you see it in the nursery. Transient strabismus or pseudostrabismus, it looks like the baby's eyes are crossed, but it's just because the muscles are immature. So we do see that. And sometimes you can have hemorrhages in the eyes because baby was squeezed so much, and edema of the eyelids. In fact, baby's face, usually, especially periorbital, you see a lot of edema right after the baby's born in the first 24 to 48 hours. So, and then you can see the red reflex if you check with a light. Remember, the nose can be is small and narrow, and also they can have a lot of swelling from the delivery again or from being suctioned. And usually now we don't try to suction the nose as much. We can put in normal saline into the baby's nose, and they will usually sneeze it out, and that will help clear the nose. Let's see. And then after the first few months of life, they aren't just specifically nose breathers. So Epstein pearls are little white specks, and they're basically little cysts in the mouth, and they're in the gum, and they disappear in a couple weeks. Some babies have neonatal teeth, and it's called precocious teeth, and it's usually a lower incisor, and if it's loose, they'll take it out. Otherwise, they just leave it. It's not totally unusual. The labial tubercle is the sucking callus. Let me see if I can. I need a baby face. So that would be right here. Some babies suck on that, so it can be very pronounced. So we look at that. And then obviously we're going to check, and you know how to do this, the palate, the soft palate, looking to make sure it's intact so we don't have a cleft palate. Obviously cleft lip you can see right away. Ears should be pliable but with ready recoil in a term baby. And the pinna should be parallel or above the inner and outer campus. And the neck is very short, skin folds. We look for webbing. We check for fractured clavicle and xiphoid cartilage at the end of the sternum. So we want to see that. It's really easy to see. Usually if the baby has a fractured clavicle, it will just not be flexed at all, and you cannot do the fencing reflex or the tonic neck reflex. They'll just hang loose. It will hang loose at its side. So that's kind of easy. And sometimes there'll be some crepitus in that area, kind of crunchiness also. Okay, so chest, usually it's kind of round. Babies are diaphragmatic breathers, they're abdominal breathers, so you're going to see the rise and fall in the upper abdomen. Cry should be strong and lusty. It shouldn't be weak and whiny. It shouldn't be like high pitched like a cat. And we always check the respiratory rate and quality, and we always check the pulse apically. And then our point of maximum endpoint is at 3 to 4 intercostal space to the left of the midclavicular line. And peripheral pulses, we'll do femoral. You might try brachial, but femoral isn't really the easiest. And I'm like, this is where I was, sorry. Or no. Wait, there. Nope. Oh yeah, that is where I was, sorry. It's getting late. So respirations, again, you need to know for sure the signs, all of these signs of distress. And we've talked about what those are. And then the heart tends to be large at birth, and it's usually closer, it's high in the chest, maybe closer to midline. Let's see. Can be regular or irregular, with or without a murmur. And oftentimes murmurs are transient. And then as those ducts permanently close or solidly close, you won't be hearing them anymore. If a baby at 48 hours old, when they're going home, if they still have a murmur, we will get an echo before they go home and follow that baby. Femoral pulses, you should try to do those bilaterally, so at the same time for equality and strength. They are hard to palpate. It's in the groin area. But if you don't have, if you have a weak femoral pulse, it can be hypovolemia, or there can be something wrong with the heart. So people who do it every day usually do just fine with that, but it's harder for us to do that. And then again, as I said before, we don't normally do blood pressures unless there's something wrong. So again, bowel sounds are present by 1 hour after birth, especially if baby eats. The umbilical cord has 2 arteries and 1 vein. It's white and gelatinous because of the Wharton's jelly. It's really a thick, tough tissue that helps the umbilical cord to not get compressed during labor. And if the baby is moving enough to not put a knot in the cord to decrease the perfusion to the baby. So, and these are what we look for. We look for extra digits or webbing. The Ortolani maneuver, we do this very carefully, never force it at all. The way to know that the baby has a congenital hip dysplasia would be when you're doing Ortolani's maneuver, you would hear a click, the buttocks would be asymmetrical. And then club foot, equinus varus, where the foot is curved, and they will do x-rays to see if it's just muscle or bone involvement, and they may do surgery or they may do serial casting on that baby. So, for term females, labia majora covers labia minora. There may be vaginal tags, and sometimes they just tie them off so that they fall off. They may have white vaginal discharge or even a little bloody vaginal discharge. That is called pseudomenstruation and or leukorrhea also, and it's just from mom's hormones. Okay. Testes should be descended, and the scrotum should be pendulous. And the more preterm a baby is, the smaller the scrotum is. We look for hypospadias. Where is the opening of the meatus? We look for a hydrocele. You can do that by palpating each side of the scrotum. Phimosis is just an uncircumcised penis where the foreskin is intact. And then cryptorchidism is when we have an undescended testicle, either one or two undescended testicles. So the nurse knows that the presence of a hip click and asymmetrical buttock folds in a newborn is indicative of A, a fracture, B, a breech delivery, C, normal in a newborn, D, developmental dysplasia of the hip, and D, obviously, is the right word. Mom of a newborn questions the nurse about the rash on the neck and chest of her 24-hour-old newborn. Lesions are 2 millimeters, white papules on a pink base. What do we call that? We call it number 4. Oh, no, not number 4, sorry. Number 1, erythema toxicum. Okay, safety concerns are important. So these are the things that we really watch for. Parents, significant others, mom, baby, they all have matching ID bracelets, which matches, and the number of the ID bracelet matches the number that is on the umbilical cord clamp. We do footprinting. We no longer really do, we do the footprinting and ID pictures for the parents more scrapbooking, because usually, you know, you wouldn't get anything to identify a baby from a footprint. And after 24 hours or 48 hours, babies look very different than they do initially while they're in the hospital. So everybody practices. We have drills for abduction prevention. The unit is locked. We ask everybody who comes in the door who they're here to see. We never carry a baby in the hallway. Always push the baby in a crib. You don't want to drop the baby. The baby's crib should be on the opposite side of the bed, opposite the door. And then we need to coach parents to never give an infant to somebody unfamiliar without a proper ID. Okay. All right, so those are the safety things. And then we have circumcision. So circumcision is controversial. Some people really think it's mutilation. There is research that, because some people say it's not medically necessary, there is research that tells us that there's a smaller incidence of penile cancer, cleaner, less chance of getting venereal or a sexually transmitted infection. So there are reasons to get it. Medicaid doesn't pay for the procedure, so the parents have to say that they're going to pay the bill. Oftentimes we do it just before they go home. And sometimes they'll wait and do it at their 2-week mark in the clinic. And so the nurses witness the consent, but the physicians absolutely have to, or the providers, give the information just before they do the procedure. They will give anesthesia. So they'll do a local anesthetic. They'll do basically a block. And we give sweeties during and have non-nutritive sucking during the procedure for pain control. We monitor them closely. We like it if they void before they go home. And then we teach parents to put Vaseline and gauze on until it doesn't look so red. And you just plop some Vaseline on the gauze, you know, mush it around a little bit, and then just put it like a little tent over that penis. parents need to watch for bleeding. If the penis is bleeding, you want to put gentle pressure on with a clean gauze, not Vaseline gauze, but a clean gauze, and hold it and call the doctor. And then there may be yellow exudate around that site of where the foreskin was taken off. That is healing granulating tissue. It's just yellow because of the urine. It is not infected. It's not exudate, and they shouldn't be rubbing it off. They should not submerge the baby in a tub until that circumcision and the umbilical area is healed and the cord has fallen off. So that's all the parent education for that, and you have those in your teaching notes. Here's the baby. We swaddle the top, and the baby has a 2-point restraint on the circ board. We call it the circ board, and the nurse circulates for it, just like in surgery. And the physicians do it, and this is basically uncircumcised. They have to go in and break up any adhesions that are there, and then they hold the foreskin up and they slide this on and pull it tight, and it basically just cuts off any blood supply to the skin, and then they just shave the foreskin off and push it down, and that is the circumcised penis. And it's going to be bright red for a couple days, and it will probably hurt when the baby voids, but we just need to put baby to breast with mama as much as possible. Try to comfort the baby. Okay, neonatal pain responses. The most common sign of pain in a baby is the cry. You can see this baby has this pain face, grimace, scrunch, and they're crying. The heart rate will go up, blood pressure, intracranial pressure. All of these things are going to be increased. Unless baby turns blue, though, usually they'll be pinker, nice and pink, or they kind of get red when they cry. Babies who are preterm, again, like I said before, they'll have blunted responses to stimuli or to pain. So, whoops, now what am I doing? Yeah, that's right. Okay, so we use, at Sanford, in the nursery, we use the neonatal infant pain scale. And to manage it, we're not, giving a lot of medication, but we'd have non-pharmacologic management. So we swaddle babies. Babies feel more secure when they're swaddled nice and tight. Non-nutritive sucking comforts a baby. Oral glucose, we put little sucrose drops in their mouth and let them suck, and that will actually increase endorphins. Skin-to-skin contact is one of the best pain relief, and breastfeeding will make the baby feel better also. Okay, so these are the things we look at, and there are 0, 1, 2 points for each. Obviously, 0 is the best score. If you have a score of 4 or above, you need to have an intervention that you're doing when you assess this baby. So, and then you can see relaxed, different from basal, breathing, flexed, angrily, relaxed, and that means they're just really tight and mad, and then uncomfortable. They may be moving around a little bit, but usually, a cry is obviously the easiest way to tell. All right. Pharmacologic management, especially like with the circ, they'll do local and topical anesthesia. For non-opioid, for a baby that's really hurting, sometimes babies, if they have a big cephalohematoma, they had a difficult delivery, we will give acetaminophen. Too much acetaminophen use, or lots of it in newborns, has been connected to childhood asthma, and so we try not to use acetaminophen unless we absolutely have to. Okay, so, and then this is what you see right after circumcision. We do recover. We check the penis at 5, 10, 15, and 30. 30 minutes and 4 hours if the baby is still there. And so these are kind of what we expect to see. Red with a large amount of, if we have a lot of bleeding, again, we're going to put pressure on that. If the baby is bleeding quite a bit and it doesn't seem to be stopping, we will use a few, there's like a little gauze that has a clotting factor on it that will help stop that bleeding and clot the baby. And so that's what we will use to stop the bleeding. Usually if bleeding is happening, it is because they've taken too much off. So, and then that exudate, the yellow exudate, remember, parents need to know that that is normal. And here we are up to promoting attachment, and that is where we picked up on the second half of the class. So I'm gonna close it up, and I'll get these posted as soon as I can. Again, if you have any questions, you can certainly email me.